Hey everybody, welcome back to the ECG of the day. My name is Reed, and don't forget that we include the PDF of the ECGs down in the description so that you can follow along and make your own notes. And don't forget to like and subscribe to the channel if you enjoy this content. So let's jump into it. So we have something here called a Holter monitor. And a Holter monitor is a wearable device. Monitor. And a Holter monitor is a wearable device. And what this does is it essentially just records the rhythm of your heart for anywhere between 2 to 7 to 14 days. And this helps us determine if someone has a high burden of AFib or premature ventricular atrial contractions or runs of SVT or VTAC, or if their sinus node is working, if they have good P waves. So this is a strip from an old patient of ours who was having some, obviously some issues. They were actually getting lightheaded often and getting to the point where they were passing out. And so this is one of their strips. And so let's take a look at it. And so as you can notice, we've got some QRSs. We'll do the top strip first. These are two strips that are not continuous. And so we have this top strip where you see we've kind of got these narrow complex beats that seem to be irregular until we get this long pause. And then we have these two slow beats, right? And so when I look at the beats over here, when I look at these beats, I see that there are some P waves. I see P waves in front of them. I see P waves in front of the next one. And then I see a pause. And something that I had noticed right off the bat is, one, those P waves are the same morphology. But two, let's talk about the rate of these P waves. And so the P waves here, they are pretty fast. So this is just under 150 beats per minute. So these are going at maybe 140 beats per minute. So that's pretty fast. And what we're noticing here is that this PR interval is shorter than the next PR interval. And then the next P wave, which is sitting right in that T wave, you see that little sharp deflection there? That's actually a P wave. That one does not conduct to a QRS. And then we see a P wave again that conducts to a QRS. And then I don't see a P wave at all. So then I'm looking all throughout this T wave and I say, I don't see a P wave there. So we get this whole period with no P waves. And so we have a tachycardia at 140 beats per minute that has P waves that are slowly increasing in PR interval until they block. And so what kind of behavior of the AV node is happening in that strip? It's a second degree type 1 AV block, or Winky block, right? The PR interval is getting longer and longer and then dropping. And then after we see this long pause, so we wonder, well, what causes that pause? Well, we are looking for sinus P waves, and I don't see any P waves. And so we get this pause that lasts for, let's see how long it lasts for. We've got how many boxes? So this is 1, 2, 3, 4. That's 1 second. 1, 2, 3, 4. That's 2 seconds. 1, 2, 3, 4. 3 seconds. So over 3 seconds. And so we know that if the sinus node doesn't beat for over 3 seconds, then we would call that sinus arrest, which is whenever the sinus node doesn't beat for over 3 seconds. Okay, and then we have this final beat here, which is appears to be maybe a sinus beat, right? Who knows? And then clearly it doesn't beat again for some time. So we have some indications that, one, our AV node is a little bit sick in the sense that it can't conduct this rate of 140 beats per minute. And two, our sinus node's also a little bit poor performing. with this sinus pause, right? We almost have a tachybrady type situation. Tachybrady. This is somewhat consistent with something we call sick sinus syndrome, where the sinus node, because it is so diseased, will just go kind of tachy and brady back and forth without really much of a physiologic indication. And then if we look down at the bottom strip again, we kind of have the same thing, right? We've got P's that conduct to QRS's. The P waves are occurring pretty fast. You're seeing that the PR interval is increasing with every beat to beat until this one drops. And then we have the resumption of PQRS, P taking a longer time to get to the QRS. And then when I look on top of this T wave, I don't see a P wave. I see no P's. I get another sinus arrest. Sinus arrest. And then we have the resumption of some atrial activity. And so it's hard to say, right? These P waves here that are conducting really fast, there's a chance that they could be ectopic P waves. Their shape is a little bit more pointy when compared to maybe this baseline P wave, but it's really hard to say. We'd probably want to get a longer strip. But we're still seeing that same physiology where here we have this second degree type 1 AV block physiology. And whenever that tachycardia stops, we get dysfunction of our sinus node, sinus arrest, and then we have this really bradycardic rhythm that resumes here, right? These two beats conduct at a rate of this beat and this beat conduct at a rate of 300, 150, 100, 75, 60, 50, like 42 beats per minute. Right, so this person's sinus node is not doing well. So even if these beats here were from some ectopic atrial rhythm, which is very possible, then this SA node is just clearly not able to recover from that tachycardia. And so, this person is on the road to getting a pacemaker in both chambers, just in case if the sinus node, right? So if we have a dual chamber pacemaker, so a dual chamber pacemaker means that I have my pacemaker box out here, and I have a lead that goes all the way down into the right ventricle, and I have another lead that goes all the way into the right atria. If we have a dual chamber pacemaker, what we can do is that if the sinus node fails, if this sinus node fails, well, the pacemaker that's in the right atria can fire off for us and make a P wave. And then, depending on, it doesn't really matter, anytime after a P wave, if the AV node fails and fails to send signal down, then my lead in the right ventricle will sense that and say, don't worry, I'll fire off and send signal through the ventricles. And so this person would really benefit from a dual chamber pacemaker because we have evidence here of AV block and of sinus node dysfunction. And so we know that we need to be able to pace both the atria and the ventricles here. So I hope this helps kind of understand a little bit more on the physiology. This was quick. It's not an ECG, but Holter monitors are really useful. And if you have any questions, throw them down to the comments. Have a great day.